Without further ado, let's make a start. So if I could introduce you to our first speaker, Dr. Guy Hanna. Perhaps, Guy, you could introduce yourself and share your slides.
Yeah, sure, Nick. Thank you very much for inviting me to speak, I guess. And I hope what I've got to say will be of use to some people. But more importantly, we want your questions. That's the most important bit from my perspective. The little PowerPoint presentation I've got to give is just to stimulate the debate later more than anything else. So let's get up the PowerPoint, and hopefully that has come through. Is that right? Is that okay, Nick?
It's come through in PowerPoint, so you're good to go. Perfect.
And Jo, as we'll talk to her later, but she's next to me. But just for the easiness, I'm going to switch the camera around so the computer's facing me. But we'll just go through a few things about CML, really, that people may or may not know. I found it difficult to kind of write slides explaining the sort of biology and the background of CML because I have no idea where to pitch it. Some people might have biology degrees, some people might not have any biology background at all. So I've tried to make it so that it encompasses all comers. So do please ask me to go forward or backwards when you have the questions to go, oh, I didn't quite understand that, or can you tell me more about that when we have the Q&A. So this is my disclosures, the usual CML people who make the drugs. So what I was going to talk about today, this isn't meant to be a lecture. It's not saying this is what to do. This is how things are done. There's no quiz at the end. And I want this to, as in, stimulate discussion. That's the most important thing. So this is what I was going to talk about. What is CML? A bit about the biology of the disease itself, what drives it, how do we diagnose it in the laboratory? And I'm sure many of you patients on the call will have had these tests when you were diagnosed. How do we treat it in 2023? And how do you make sense of your blood results? And that will come back a little bit to the biology of CML, a little bit to the laboratory testing and diagnosis as well. So it all links together. So what is CML? So hopefully this won't be news to anyone, but CML is a type of blood cancer. If you've been diagnosed with CML and someone hasn't told you that, that's not ideal, but it is a type of cancer. But as you hopefully know, is a type of chronic cancer that is well controlled. And this is what we tell people when they're first diagnosed. But what is cancer, more importantly? And so you can look at it in scientific terms and go through lots of papers and find the 7 hallmarks of cancer that define what makes cancer or a neoplastic process. In simplistic terms, it's something's gone wrong with the DNA of the cells, and this creates uncontrolled growth in those cells. And in CML, there's something gone wrong with your blood, your bone marrow stem cells, which means you get too many of your blood cells. Most hematological cancers have the same sort of principle, but and all cancers have that principle. So some cancers have very complicated genetics. Lots and lots of things have gone wrong with the DNA to create cancers, like, for instance, melanoma, skin cancer, very complicated genetics. CML, one of the simplest. So literally one thing goes wrong genetically with CML, and that's enough to create cancer. It's quite rare in that case in terms of cancer. So, but that does mean that we can monitor it and treat it, and I'll come to that later. So in some cancers, the problem starts with the DNA you're born with. You inherit a predisposition to cancer. That is not the case with CML. We tell this to everyone at diagnosis. There's nothing you can inherit which makes you more likely to get CML. It's, again, not the same in all cancers, but we know this is a one-off genetic hit, and therefore it's not something that you can, you've done anything wrong to get, nothing that you've done, it just happens randomly. So what I did is I found a really nice website. So please, if you have a look at this, how does DNA work on the Science Me website, it's got some beautiful cartoons of the biology if you're not completely familiar with it. So this is essentially what our DNA looks like. So on the right, we've got the chromosomes, which you might be able to see under the microscope. We'll come to that in a minute. And within that, get smaller and smaller, more microscopic. You essentially have this ladder, this double helix, which makes up your DNA, which is essentially a code made up of 4 letters, which tells all the cells in your body how to do everything. This is what the cells look, the chromosomes look like down the microscope. We have 46 in a normal human, and they come in pairs. So you get one from mum, one for your dad. And essentially when we look at them for diagnostic purposes, we arrange them like this. Now, this is actually a CML a chromosome. So you can see this little mini version of 22 here, which I'll come to in a minute, and a slightly longer version of chromosome 9 here. So, I mean, what does DNA do? That's an important thing to go back to when we want to think about CML and the biology of CML. So think of your DNA as a big old recipe book of how to make a human. And little chapters. So we've got chromosome 9 is a chapter 9, for instance, chromosome 22, chapter 22. This tells you how to do certain things. And within each chapter, there are genes, so or recipes for certain dishes. And what happens is when a cell goes, oh, I want to make this dish, I want to make this recipe, it makes a copy of that DNA called RNA. And this RNA floats off in the cell and finds another bit of cell, and then another bit of the cell apparatus turns that RNA into a protein. And that's all it does. That's all DNA does, is it encodes protein. It tells your body what protein to make, and then that protein does other stuff. And that's essentially how the entire human body works. And that's an important sort of first principle to think about what happens with CML. So what happens with CML is those chromosomes that we just saw before, again, bit of chapter 9, bit of chapter 22, they've swapped over. This is your BCR gene here and your ABL gene here. And what they do is they have a little switch over. So they create this ABL BCR, which doesn't do very much, but they also create this BCR ABL, which is basically two genes stuck together. And what that means is that you have effectively two proteins stuck together when your body turns that recipe, that DNA template, into a protein later. And it's that protein, that BCR-ABL protein, which causes all the problems in CML. So again, I'll come back to this very nice cartoon. I think it's a good way of thinking about it. What happens in CML is that there's bits of someone's taken a bit of chapter 9, a bit of chapter 20 and swapped them over, put them in different parts of the book. And therefore, when it wants to print out this recipe for this gene, it's got two recipes stuck together. It's like having a recipe for shepherd's pie and trifle and going, I'll have 2/3 of a shepherd's pie recipe, 2/3 of a trifle recipe. I'll try and make that. And the protein you get is, let's just say, unpleasant. And as I'm sure many CML patients know, it's not nice having CML most of the time. But that's what happens in your body. It creates this protein which is wrong. It's the wrong recipe that's been made. It's made up of two different dishes which should be separate. And what happens is that protein, the normal ABL, this is our ABL some kinase, this is what it's called, normally has this little orange tail. And this orange tail gets there and stops it working most of the time. And then what it does is it causes your cells to proliferate and grow. And most of the time, this tail is sitting in there in the protein saying, don't grow, don't bother growing. We don't need to grow this cell at the moment. And in some conditions, it will say, oh, actually, we need to grow now. In BCR-ABL, in CML patients, that little tail, which stops that happening, is missing. And you've got this silly BCR bit of protein, which shouldn't be there, stuck in the end of it. So now this protein goes, oh, I've got no one telling me not to go about my business. I'm just going to go and make loads and loads and loads and loads of cells. And that's how CML happens. And that's why we get loads and loads of cells in the blood. That's why you get high white blood cell count when you're diagnosed with CML. And this is a picture of a patient with CML's blood film that I took just yesterday. So that's the principle of CML. I hope if you've got any questions about this, I'm really happy to try and talk through a bit more. I don't know how well that's communicated, and I don't know if that's been a bit too above some people or below some people. I don't know, but hopefully given a good overview. So how does it behave if left unchecked? So in the old days, before we had good drugs and people who couldn't have stem cell transplant, they might be able to stabilize them and suppress the CML a bit for 5 to 6 years, and then they might have 6 to 8 months being accelerated, and then eventually they become blast crisis. And they would die of the disease because it wasn't being able to be controlled. Luckily, for the vast majority of patients, that's not the case anymore, and we've got stuff to stop it. And we've got stuff to stop it because we know exactly about the genetics of disease, and we know exactly how to target that genetic problem. So how do we diagnose CML? So the journey almost always starts with some sort of interaction with a GP or maybe an A&E or someone who's not an expert. And they, as doctors, when you trying to find out what's wrong with a patient, you need the history. You need to know what symptoms people got. So people, when they're diagnosed with CML, often have fatigue or lethargy. They may be anemic. You can have abdominal swelling and bloating. That's because of the enlarged spleen. You can have night sweats, weight loss. You can sometimes get bruising and bleeding. And then someone might examine you, and the most common finding would be the enlarged spleen, which is typical of someone diagnosed with CML. And then someone who comes up and says, oh, well, I think we'll do a blood test. Well, they might do a blood test for another reason and find it incidentally. But the blood test makes a non-specialist go, oh, too many white blood cells. Oh, I don't know what to do about this. Or they're anemic. I don't know what to do about this. Let's ask a hematologist. And then it's up to the hematologist to do the diagnosis for you. So what does the hematologist do? So first thing they'll want to do is look at the blood down the microscope. And again, I'm going to show that lovely picture again of a CML patient in the microscope. Now, I haven't shown you a normal blood film, but basically there probably should be about 1/10 of this number of white blood cells, probably even less than that, in a normal person's blood film. So that's a smear of blood on a microscope. This has got far too many cells, and what the cells are is what we call granulocytes and mainly neutrophils. All these ones with funny lobes are neutrophils. So this is what we can count down the microscope. And these other ones, these bluier ones, are immature cells, which happen when you're diagnosed with CML, when you're first diagnosed. And we've got some orangey ones here, which are your eosinophils. So if people talk about eosinophils, they're nice orangey cells in the blood film. And I'm sure I could find a basophil here as well. I'm not going to go into detail. So look down the microscope and go, oh, this looks like CML. So what do you need to do there? So two things you need to do as a hematologist. You need to detect the B-cell-ABL, because the CML is defined by that genetic problem we talked about of the chromosome 9/22 switching and the product of that, which is the BCR-ABL. And you also need to find out a little bit more about the disease. Come to that in a minute. Often the quickest way we can detect the presence of the CML is with something called FISH testing. Now, again, I'm not going to go into all the details of there are many different ways to detect BCR-ABL, but often the quickest way is we can do FISH. And people go, what's FISH? Are we getting our rod out? Well, that's how I talk to my cytogenetic scientists. But actually, what we do with FISH testing, it's called fluorescence in situ hybridization, is essentially we're looking for the chromosomes and the genes on them and to find out if they're in the right place. So normally, if I can show you this bit here on the way, this is your normal chromosome 9, and it's red for the ABL, for the BCR, sorry. BCR is red, and it's all in the same place. That's where it should be. And on this green one, this normal chromosome 22, the green is all in the same place, and that's where it should be. But what happens when you have a swap of the chromosomes is that the red and the green swap to be next to each other. So you get actually this nice little yellow signal. And that just tells you that the BCR and the ABL are stuck together to create this BCR-ABL fusion gene. And that's what we can detect by this technique. Also, bone marrow biopsy. I'm not going to linger on this. This is not the nicest picture. For those, I'm sure most of you have had a bone marrow biopsy. Hopefully only one. Most people only need one. And it's there to tell us the stage of the disease and about other DNA abnormalities as well. So how do we monitor CML? So we need to exploit the genetic abnormality. We've got that BCR-ABL. Luckily, we can measure it. So basically, we grow more BCR-ABL in the lab. We basically do a polymerase chain reaction, which is we take the DNA, split it in half, and then grow a new bit of DNA in each half, and then keep doing that and build up more and more DNA. And we can measure how quickly BCR-ABL builds up compared to another gene, and then we can decide how much BCR-ABL is. And it's really nice and sensitive test. And again, I'll come back to this nice diagram. What we're actually measuring when we're testing a BCR-ABL is the mRNA. So the RNA is the most reliable measure of how much BCR-ABL there is, and therefore how much CML there is. Unfortunately, this RNA, or the recipes that have been produced from your recipe book, only lasts about 3 or 4 days, 2 or 3 days before it degrades. That is why we need to get those samples in the laboratory within about 42 to 72 hours, so that then we can we go back a stage actually in the laboratory and create what we call cDNA or complementary DNA. And when it's nice, stable DNA, then we can run these tests, and that's the idea. And then we can count better. So that's why we say often don't get your blood test on a Thursday or Friday. If it's sitting in the lab over the weekend, these are specialist labs, they only run during the week normally, then actually your sample is going to be too old to be processed. So that's what we do. We turn it into DNA first. Okay, so that's a sort of overview of that. How do we treat CML? Right. Again, luckily, the science is really far ahead with CML compared to other diseases. And it was the first disease where we found something to block the specific abnormality. So that BCR-ABL that's created, normally, it will just go up. I'm going to turn this ATP. I'm going to do whatever I want to do, and then I'm going to have the downstream effects and proliferate the cell. What imatinib does, it sits in there, sits in this enzyme, the protein, and blocks all that effect. So it specifically goes to that exact spot on the BCR-ABL and sits in there and blocks it. So that's basically how it works. And they were the first targeted anti-cancer drugs, and that's why that's why we're very lucky in CML to have them. The effect of them. So this is what this is the survival of people before imatinib. So if you're not familiar with this, is a Kaplan-Meier curve. Don't worry about it. It just shows you what happens to people. So with people with CML, when they're diagnosed, this shows you how many are alive at any one point in time. So after 2 years, about 90% were alive, and then maybe after 4 years, we're about 70% alive. So basically, gradually CML patients were dying over years. By 10 years, not many people still alive. That was in the 80s and 90s. As soon as imatinib comes in, this is what the curve looks like now. And it's probably even better now than this early data in the early noughties. The drugs have had an amazing effect on keeping people alive and keeping people away from hospital as well. But basically, in simple terms, it keeps people alive. So as you can see, by 6-7 years, you've still got over 90% of people alive. And this is on the earliest clinical trials. Again, not real world data, but I think the point is that it's done such an amazing job for CML, these drugs. So what's available there for you as the patients in 2023? So there are essentially 6 drugs available, all available at different lines of treatment. We also often classify the drugs into first, second, or third line or third generation treatments, just as how quickly they came and the things drug companies do to make them. And then the sort of fourth line, or the newer drug, asciminib, which actually works in a slightly different way to the others. And this is who makes them, and this is where you can get them in the UK currently. So first line, first treatment CML, you have 3 options. And what you choose, we weigh that up on a whole lot of different things based on the CML, but actually mainly based on the patient. And I'm not going to go into the detail today about where you would choose when. That's just a very brief overview of what we've got to treat CML with now, which is actually amazing considering what other diseases have got to treat. We've got such a wide and amazing variety of things that we can do. And what are we aiming to do these days? Back in the late 90s, early noughties, we just wanted to stop people progressing. Now, actually, we want to get people into MMR, and nowadays we want people to go into deep neck response if we can, and even be able to stop the drug in the future. We know a certain proportion of people can get to that point. But thinking back, I was saying the choice of drug at the start. Again, it's that balance between what do you want to do, what are the pros and cons of giving imatinib versus your dasatinib and lostinib up front. But again, completely revolutionary our thinking of CML. We didn't want to keep people alive for as long as possible. We want to keep people alive for a long, long time with a normal life expectancy, and hopefully with as normal a life as possible as well. So what's the testing strategy? So it's all about measuring your BCR-ABL, and we can measure down to very, very, very small amounts. So this is what your standard baseline is 100%. So all your cells have got CML. And then 10%, we call that MR1. And then basically this is up. We use a logarithmic scale to go down. Then it goes to 1%, 0.1%, etc. And it can keep going down and down. And the lowest we can measure is 0.001%. So it's MR5. And actually, some people are even below that line or have undetectable BCR-ABL. So that's what we go for. And what do we try and do at any one point? So this is the national guidelines about what we aim for a BCR-ABL. And this is what your doctor will probably be focusing on when you're treating your CML. They also need to think about the side effects the treatment's giving, and I'm not going to talk about that in detail today, but this is the blood test that we're doing to see how well your CML is doing. At 3 months, we really want to get that BCR-ABL to less than 10%, if possible. At 6 months, we really want to get it below 1%, and by a year, if we can get it to less than 0.1%, that's a win, and then we want to keep it there. So these are the milestones that we want to go for in CML. So that's the BSH guidelines. Luckily, the European guidelines are exactly the same. So how often should we be monitoring you? Essentially, every 3 months is the basic strategy. So, and every 3 months for quite a long time, unless you're really, really stable. Key time points, as I said, 3, 6, 12 months. That's when we really want to know how you're doing and get people into boxes. We can check early response, not always in all patients. Key thing is that we can increase that monitoring if we're not quite happy with where those numbers are. And I'll often, if people aren't quite where I want to be, I'll see them every 2 months and make sure that, or even more often if necessary. Obviously, if you switch drugs for different reasons, we do a little bit more often when we do that. And also if we reduce dose or we go for treatment-free remission, we often increase the monitoring there as well. So the point is, lots of things change, increase the monitoring. That's my general strategy. But the important thing is that the treatment for CML, whether it be the choice of drug, the monitoring strategy, the dosing, is not this is the same for everyone. It isn't a one size fits all. It really is bespoke for every single person. And it's really important to remember that you're an individual. It's about you as the patient, not about your disease only. It's about you and fitting the drug into what you need to do. So there we are. That's my whistle-stop tour of CML and the biology behind it. So hopefully that was useful. Thank you very much to my colleagues, Joe sitting next to me, Joanna, who I'm sure many of you have met on other webinars before, who's a trusted colleague and mentor. And thanks to Nick and the Leukaemia UK team for inviting me. And thank you for listening. And more importantly, thank you in advance for all the exciting questions you're going to provide.
Thank you, Guy. Really, really fascinating way you've explained things. And we've already had some positive comments about that in the bar, in chat. I think I'm going to be thinking about DNA and dishes when I'm cooking tonight. Really interesting.
I'm just going to say, I have just noticed this laptop may run out of battery. So I'm going to leave you with Joe while I run and go and get a charger for
Okay. That's great. On that note, I'll just let everybody know in the audience that during the stages, we will, hopefully you'll find the charger. We seem to be having our fill of tech challenges today. And one of the things we'll look at approaching later on as well is a little bit more closely at understanding blood tests. And there's plenty of questions from everybody. Please do keep them coming, and we will address those a little bit afterwards when Guy's back and we've heard Joanna's presentation. Joe, over to you. Please introduce yourself, and thank you for joining us today.
Thank you very much for asking me again. It's really a great honor to be asked to come and speak to people, and people who are, have some feeling for, how they might be feeling, whether that's people who are quite new to CML, for whom this is all, very, very new, or people who may have been living with CML for quite a long time and just want to sort of stay involved and keep their understanding fresh. Very often what happens when you're diagnosed with anything, whether that's a hematology issue or any other disease, is you feel a little bit like your proverbial rabbit in the headlights. You get given a whole lot of information, lots of booklets. Somebody either takes a lot of time and tells you a lot of information, or is fairly perfunctory with you, and you sort of you either alone or with your loved ones leaves the hospital and often doesn't know where to go or where to take that information. And when you get home and people call you, how did it go, what's happened, sometimes it's really difficult to take that language, take that information and find the language already to be able to to be able to explain and update those around you, let alone yourself. And I think in many ways that's, probably one of the key things that having a nurse specialist working with your team really adds. So completely get that. I don't come from a scientific background. I think the last biology I did was, age 15 and a half, labeling a daffodil. So I completely understand this. This is a new language. I have to admit, before I became a nurse, I didn't know my blood was made in my bones. I'd never given it the slightest thought. It was something red and it went around my body. And I had lots of other things on my mind, but questioning where my blood comes from definitely wasn't one of them. And I don't feel too bad about admitting that, because over the years, I've met almost, I'd say, most patients. Everyone's rather afraid to admit it, but most patients, and I've even had people, very eminent patients who are also not aware of that. So I think understanding that we're starting with something quite complex that none of us are very familiar with is kind of how I approach being a nurse specialist. And I completely understand that when you come away from that first meeting, however applied you are, with your notebook and your pencils and writing things down, you can often come away, go and have a cup of tea, get home, and then you look at it again, and it's really, really hard to put all those pieces of the puzzle back together. And I think especially in the initial sort of 3 to 6 months, but even much later down the line, having somebody who you can call up or send an email to, or you see in the corridor or whatever it is, where you can say, hey, would you mind just running over that? I understood it when the doctor said it, but now I'm finding it really difficult to reproduce that information and really difficult to understand it. And, I'm quite a layman as well. And, I'm happy to go over those things as many times as it takes. I mean, I imagine myself in the same situation. I might not, despite being a hematology nurse, I might not read the masses of information and the heavy booklets. I might just want some understanding and to put myself in somebody else's hands and trust them. And there's lots of different levels of information, as Dr. Hannah said.
A couple of questions. I'm going to just pull them out from everybody in the audience. I just wanted to explain again to everybody while they can hear, not to panic, because we do have the following up with a national support group where Professor Joanna and Joanna will be participating in that meeting to help everybody with expanding on questions and discussion from Guy's fabulous talk, and to be able to explore the supportive care areas. So just answering, we're confirming Guy's presentation will be available ahead of that. Question, can you say anything about treatment during pregnancy? Somebody commenting about, you can see in the chat, about being on imatinib and out of treatment again. Any thoughts there? I know it's personalised, but just because obviously you brought the topic up also.
Yeah, it's a big topic. Is what I would say. CML pregnancy, as a rule, for women taking TKIs, you shouldn't become pregnant on TKIs. They do cause damage to the unborn fetus. We always get people to stop if they become pregnant on TKIs. We don't, and if people want to become pregnant, we get them off the drug. That's the general rule. It gets more complicated than that because there are other things we can do. Joan, anything to say about pregnancies?
Yeah, I mean, it's very tricky. People need to be, with a very, very low level of CML, with very low BCR-ABL, and it can be a point of great anxiety. I would think the key thing to do is to make sure that you're with an actual CML specialist. So if you're being treated, very reasonably by a more general doctor in a hospital outside of a large centre, I would ask that you make sure that you were referred into a specialist CML doctor to manage that. That's depending where you are, I'm sure that your haematologist will understand that, and if they weren't already proactive about that. It comes with risks, but it's obviously something that's really, really key to a lot of women's lives, and it's not off the cards, but it needs very expert and very careful management.
And just a quick point for the men on TKIs, although it's officially you shouldn't get people pregnant on TKIs, there have basically been no reports of any problems with babies born to men who've been on TKIs. So we're a bit sort of a lot looser with that. So men get away with it again, I'm afraid.
Thank you, Guy. Yes, I'm mindful of time, so I'm going to try to see if we can segue into a little bit of blood tests. And one of the questions that's still sitting here from earlier on is when you were talking about monitoring frequency. I have a question there from somebody who's unsure about monitoring frequency if on treatment-free. Is treatment-free monitored monthly? So I'm not sure whether that would be treatment-free before first treatment or treatment-free after stopping treatment.
So that's probably someone asking about treatment-free remission, which is certainly a hot topic in the CML community at the moment. Sorry. So yes, there are official guidelines, national guidelines, which tell you what to do. We think they're a little bit too strict at the moment. They may be updated, but essentially it's monthly for 6 months, and then it's 6 weekly up to a year, and then it's 2 monthly for another year. So essentially there are guidelines out there for the people to monitor, but yeah, the most important thing is to do it quite often for that first 6 months, because that's the most important time for treatment-free remission.
Thanks. Excellent answer. This is probably not the webinar for it, so I just want to raise it, because if it's not your area of specialism in terms of pediatrics or teenage and young adults, there is a question in here around a asciminib and prescription around if, it's segueing again, you mentioned guidelines, so it was a guidelines question. Do you know if of any access, compassionate access schemes or something for somebody that might have failed 2 TKIs in the younger group? Is that too complex a question? Is that something that maybe our advocacy officer could follow up with your expertise?
It's a very good question. It is quite specific, and it's quite, luckily it's not asked very often. I guess we're lucky that there aren't too many young people with CML. I guess in one respect that's lucky. And most of the time they respond quite well to treatment, and they tolerate treatment quite well, our young patients. I don't know the answer to that. We know that there is a compassionate access scheme to asciminib. I don't know what the company are allowing in terms of access for under 18s. That is a good question. I kind of quite want to know the answers myself now, so I may ask my contacts in the parties.
Well, that's great. Well, if you do that in the background, what I would ask the person in the audience to do is also to contact Leukaemia Care. I'll put the information up at the end and speak to our advocacy caseworker who is actually on this call supporting in the background, and they will also be able to look into that to help you, because it sounds like a very significant and important question. Now, I'm going to struggle pronouncing this, but it's there. Any link between CML and multiple osteochondromas? I don't know what that is, but
so off the top of my head, I don't think so. Essentially, there's not really any links with CML, the disease, and anything else really, because it is a one genetic hit disease. So I can't think of anything, but I'd have to look it up to be sure. But if I was to guess, best guess, I'd say probably not.
Okay, thanks. And they're peripheral on topic, but just a question here about, are there any associations with CML and blood clotting?
That's slightly more complicated to answer that. So when you're first diagnosed, if you have a particularly high white cell count, you can get what we call leukostasis. It's not really blood clotting, it's just your blood thickly moving through the blood vessels because there's just too many white cells, and that can happen to some people at diagnosis. Generally, you can have sort of not blood clots, but thickly blood moving to the eyes and the lungs can make you breathless, that sort of thing. Once you're well controlled on treatment, once your white count is below 100, actually doesn't really happen anymore at all. And then the biggest problem with blood clots is that some of the treatments are more associated with blood clots in the heart or for strokes and things like that. So they are the things we worry about in terms of blood clots are related to treatment. But in terms of, say, a DVT or something like that, or a blood clot in the veins, not really. Essentially, CML doesn't really increase it that much compared to a lot of other cancers. I think all cancers can increase the chance of blood clots, but CML normally well controlled quite quickly, and therefore your blood clot risk is not increased by the CML after probably about a month of treatment, hopefully, or two.
Thank you, Guy. I'm actually looking at how many questions have come in, and I don't know if we're going to be able to address all of those. But did you touch on, there's one question that just some simple explanation first. Somebody wanted to understand the difference between first, second, third line therapies. Did that mean the generations? But I think that was just purely you were explaining your first, your second, and your third possible treatment as. Yeah,
absolutely. So generations is just how early the drugs were discovered effectively and in groups. And then the line of treatment, as in what you get. If first line is what you get when you're diagnosed, and if that doesn't work or you get intolerance, then you move on to second line. So absolutely, that's what it means.
And I'm just going to offer one more broader question. There's a few questions around transplanting. Really, is when is transplanting considered in CML?
Okay.
I think you might have seen the questions come in before you were on your phone, but
yeah. So essentially, transplant is when simply the benefits outweigh the risks, and with transplant, because there are significant risks of mortality and certainly morbidity, so dying or being completely wiped out by transplant, you've really got to really want to do it. So in general, it's people with advanced stage CML, so blast crisis CML, who might need chemotherapy beforehand. They would normally have a stem cell transplant, or if you've run out of the other TKI options, you've run out of your normal drug options because either you can't take anything or nothing has worked. So those are the options where we go transplant, and you've got to be fit enough. So above a certain age, and we don't have a strict cutoff, or if you've got significant comorbidities, then transplant becomes even riskier. So it's for younger people. I say younger people. People in their 60s can still get transplanted quite happily a lot of the time, but even in younger people, it's still a risk. So it has to be sort of the last option for most patients.
Okay. Thanks. So that kind of answers that first question in terms of guidelines. Do you have to have had 3 lines of therapy before, or would there might be personal circumstances that would differ to that? Do you have to?
No, it's not as simple as that, but essentially you want to run out of your other options. It be the best option before you go for transplant.
Okay. And on that question, I think you kind of answered it. Are there guidelines with regards to fitness before a stem cell? You know, how important is age as a factor? And you were kind of saying there that age is important, but that there will be other factors that would be considered.
Absolutely. And again, it depends on the disease situation or the patient situation. It's that pros versus cons when you're considering transplant. And the older someone is, the more other medical problems they have, that weighs on the cons a lot more often.
Thank you. We will try and address any questions that aren't answered that have been fielded. We'll pick those up and look to see if we can address those in the next session. I'm mindful that we were going to talk a little bit more towards understanding blood tests. And from my take of listening to the complexities involved of the genetic element of the special genetic tests that are required in CML, this is something that needs doing in a specialist centre. So 2 questions. The first one leading into understanding, Robert, where and how do these blood tests have to be provided? You know, can patients be managed in the community? And so it's a double-edged question on that with regards to, you know, the blood tests and obviously how can supportive care, who's there to support and to help manage that, and the link up which is the clinical nurse specialist, I would assume, with the GP. And then can we just then move on to a little bit of discussion about how to understand your blood tests, how to make sense of them, who to talk to, what are the most important things to look at in your blood tests?
Okay, so
in the results, because that's the point. Yeah.
So simply, the blood test, the CML treatment and monitoring is delivered in the community. So your touch points with hospital are you're having your blood tests, your consultation with your clinician, your CNS or your consultant or your pharmacist, and then your prescription, your medications, and that can all be done at home. We do lots of telephone appointments now. A lot of centres, we don't do it, do sort of remote blood testing, especially in other parts of the country where, I mean, we're in London, so people are normally quite close to it. But the blood tests go themselves to normally specialist laboratories in hubs, and there will be probably about 12 of them in the country. But that doesn't mean that every hospital can't send that test to that specialist centre. And every haematologist will have a network that they work with where they're specialist testing, these specialist cancer tests, the BCR-ABL, they will have a pathway where those samples will get to the specialist laboratory. The issue with BCR-ABL is that, as I said, you need testing ideally within 48, if not 72 hours.
That's why I raised that question, I think, yeah.
So it's just about logistics of getting those 4 tubes, normally 4 tubes of blood, from where you get it taken to that specialist laboratory. And as long as that works, then that works. It almost doesn't matter what the bit in between is, as long as you can get that to work. So it's a logistical question more than anything else, really. It needs to be done in the specialist laboratory because it's a rare test, but can be done anywhere as long as the blood gets there in a timely manner. And then the second part of your question was about how to interpret the blood tests.
I think that's the important part there, is what, as a patient, when looking at the different cell lines, the different tests, what's important to manage and monitor so that patients are involved in understanding and managing the most critical elements, and with understanding.
So I might let Jo answer that one, because actually she has to explain this to patients quite a lot. So
that's a good segue, because I think Jo is also the link up when people are managed in the community, so you obviously have some perspectives on that as well.
Yeah, and it depends on, exactly as Dr. Hannah said, it depends on what service is actually set up. I mean, there's pros and cons of having blood tests taken in the community. Some of them are cons for me, and some of them are cons for patients. We do need to have the blood in a timely manner. It is, unless you're very, very sure of the system, there's a lot of pitfalls about having it in the community. If we can get it working, it's fantastic, but we don't often have the infinite capacity to chase up the results. So, what we really need to see at the very bottom level is a BCR-ABL, and in some sense, if someone has got the correct blood forms and a place to go, and they're booked in and all of those things, that's sort of, and they go early in the week, so they reach them in time, that's okay. But then we need to get back your full blood count, because we need to know what effect is the medication having on your blood count, and we need to make sure that your liver and kidneys are okay. And sometimes those tests you would think that would be much more simple to get hold of, those tests are much more complicated to get hold of, and sometimes it just comes down to numbers and the capacity of your centre to be able to retrieve them. And different patients will be more or less proactive about that, and different centres will be more or less helpful about that. So unfortunately, it's not yet a one-size-fits-all. In terms of understanding the blood test, I think it's you need to have a good understanding of the medication you're on, and the likely or not likely negative effects they might have. So, say take a tablet such as nilotinib, which we know over time can have an accumulative negative effect on your cardiovascular system. So we need to make sure that your cholesterol isn't affected. We need to make sure that your blood sugar isn't being driven up. We need to keep an eye on your blood pressure as well. Make sure that different enzymes such as amylase and lipase are reasonable, and that we're not causing you more or less damage than we're helping you. So having a really good understanding of what the side effects or the negative effects on your blood or your body of the tablet that you're on is really important, because that's the monitoring. The monitoring is quite tailored to the tablet. And I think that's quite important. So for anybody on ponatinib, they'll know that similarly that has a similar profile of side effects to the nilotinib. For dasatinib, for example, it's a lot more to do with sort of breathlessness. Bosutinib can cause gastric disturbances commonly, and it's about you working with your team to understand how that tablet might affect you and how we can manage that, and that will determine some of the blood tests. So a full blood count will look at a number of different things. It will look at your hemoglobin, so how many red cells are carrying oxygen around to all of your cells, and if the tablet affects that and makes that a little bit lower, then it might be a little bit anemic. We might need to think of ways that we can combat that if it has an effect on your quality of life. If your white cells fight infection, and about 70% of those are neutrophils. If they're too low, you could be at risk of infection. And again, we don't want to cause you additional harm. If your platelets are a bit low, so platelets are the little kind of super hyperactive sticky cells that when you look at a scab, what you're really looking at is dried platelets who have come along to stop you bleeding. And there's other cells within that, and there's other measures of your blood, like the viscosity of your blood, or how many cells are packed within a certain volume of your blood. So we're looking at all of that, but we're also looking at your liver and your kidneys, making sure, because most of these drugs are processed through your kidneys, that it's not causing you any long-term damage, that your liver isn't being irritated by the drug. So with CML, it's about getting a balance of a tablet that works for you, i.e. it stops the BCR-ABL from proliferating and causing you to have a more dangerous form of leukemia. But it's also about what you can tolerate, both in terms of what doesn't affect your blood tests too severely, but also in terms of what you can tolerate in the way that you feel. Are muscle aches and cramps and fatigue, are they just impairing your quality of life so badly that you're not enjoying life, or you're not able to do the things you want to do? Is dasatinib making you too breathless, or bosutinib mean that you're scared to go out because you need to keep running to the loo? And this is about how you work with your team to talk through all of those things, that we have a really good picture of where you're at, so we can find that balance between a tablet that's working objectively but is also tolerable for you, that lets you live your life as well as can be. Does that make sense?
That does. I mean, that gives a really good broad holistic overview of how different therapies maybe have potential things that you want to be looking out for, and they're broader. And I'm sure we can signpost to resources where you can get more of an insight on this, either through Leukaemia Care, understanding CML, understanding blood tests. And we will make sure that we signpost to everybody to these resources after the event. I guess one thing flags out me, that obviously there is those that are trying treatment-free, and that there are those that are trying to approach treatment-free, and there's also the marker of the key genetic markers of potential progression. And that's something that patients often do think about, because they might be, although other bloodlines and other issues might show progression, I guess that's one specific. Are there specific markers that if patients want to keep an eye on things that are indicative?
Yeah, so absolutely. I mean, when we talk about what's, important milestones at the beginning of the treatment, the 3 months, the 6 months, the 1 year, what we're looking for is to be able to plot those on a particular downward trajectory, so that after a year, we're looking at somebody who's in or approaching a major molecular remission. So they're meeting their milestones as we go along. It isn't absolutely essential. They're guidelines, and it doesn't mean that we need to start panicking if people aren't on those at all. But that's what we're looking for, to meet certain milestones. And then what ideally we'd like is for everybody to be in a major molecular remission. So that's at least 1 0 on either side of the decimal point, and to stay there. But it's not a failure if that's not the case. It depends on lots of things. Might be somebody, for whom pushing up a dose is going to not be something that they can do. Say, for example, they've got very poor kidney function, are very elderly, or lots of different reasons, and then just to keep them stable, to keep them held somewhere, is okay. So we're tailoring the goals of treatments to that person. So it's very difficult, and I don't want to make anybody here on this talk feel like they're failing the goals of treatment because they don't have 2 zeros. We have to be really sensible about what's achievable, and hold people in the safest place we can. We rarely these days lose many patients to CML. Some patients go for transplant and that they can have complications, but sometimes just holding somebody stable somewhere before they reach an accelerated phase of CML, that can be enough.
I think you really did. That's a good point to draw things to a close and to point out, and thank you. You've been really clear on that, and that's why I raised that, because I know quite passionately that it's not a one-fits-all way that you would want to manage your CML, and the end game isn't being treatment free for everybody. It might just be holding the disease at bay so that you can live a life within the toxicity profile and your quality of life that you need, and that's a personal choice, and that's something to talk very closely with your care team about. Coming back to understanding your bloods, I think we're going to extend this conversation in the follow-up national support group meeting, where people can be more involved and more inclusive, and patients can talk to patients and share experience. Joanna's going to be at that, and Professor Dragana is going to be at that one. So on that note, I'm just going to put some slides up to everybody. But before I do, I just want to thank the ingenuity of our panelists, who have had to do so much to stay on this call, and apologies for what happened before, because unforeseen to yourselves, the central system we had issues with, that our fantastic speakers have had to run around their offices and find an alternative way. And even when that broke down, that they're on the phone to us. I mean, that just got to be the marker of dedication.
It's modern life, right?
It's in modern life, and a sign of dedication. So listen, I'm going to pull up these slides and just run out to everybody, because I'm mindful we did start late and we've run slightly over to allow for that gap where we couldn't hear each other properly. Bear with me whilst I now try to find these end slides. We have them. And I am in the same boat at the moment. Apologies. Can you see my slides, everybody? Hello?
We can see them, Nick.
You can see them. Hello?
Yeah, we've got them.
Right, apologies. I'm trying to get on slideshow myself now, and I can't. Sorry.
See them.
If I stop share, Sophie, would you mind sharing from your side? Sorry. Oh, that's excellent. If you're able to pop it on slideshow. It seems to be a day of technical issues today. I'm glad you're there on the call. We have slideshow. So listen, just to finish out to everybody, thank you for joining us today. I just run through a few supportive resources that Leukaemia Care can offer you, and obviously signpost to this next meeting so that you can actually pick up this discussion, and hopefully we can enjoy it, fill the spaces that we lost due to sound today. So services available from Leukaemia Care, many information sources, webinars like these. We run a regular newsletter. And we also have our Leukemia Matters magazine, which is full of useful information and experiences of patients, advances in treatments, etc. Podcast is another way that you can pick up information. Some people like to listen rather than watch whilst they're doing activities. We're very active on social media, and the website really is the plethora of information, the place to go. If you go visit the CML section, visit support group session, visit other areas, you can get a lot more information, especially around the topics we've been discussing today. Next slide, please. Booklets, these are key. We've got several booklets available in CML around treatments and around information, general information about CML. And apologies, there seems to be a carried forward abbreviation in there for ALL, that's a typo. But you can pick up any of our booklets, either the more generic ones, living with a condition, talking to others, understanding a diagnosis, learning about chronic myeloid leukemia treatments, learning about different aspects of CML. Please do visit the website. Support services we offer, the helpline and a WhatsApp service. So we run a helpline that's staffed by our clinical nurse specialists. And we also have a WhatsApp group as well for those that may not want to talk in person. And Sophie, who's on the call, our advocacy officer, is very much involved in responding to those, and will be there for you if that's the route you prefer. Virtual support groups, we've got a network across the country of about 60 support groups. I think about 23 of those are national support groups in different indications, in different conditions. And many local support groups that can bring you in contact so that you can share experience and learn together from others living with the condition. We have a welfare advice officer who's incredibly important, especially in these times. It is a struggle for everybody to meet their commitments, especially when it might be traveling to hospital, or it might be going through early treatment, or it might be other. Please do get in touch. You can do that through the website. I'll give you a little bit more information on another slide. And advocacy and support. Well, our advocacy team and our advocacy officer, Sophie, is on this call. She's there for you on the end of the phone, either as a caseworker or to answer any challenges or any questions you might have with regards to your care, support, or information. Online forums, we run Facebook groups, and we have the buddy scheme, which I'll talk to in a minute, and we also offer a counselling fund. This is what I was looking for, and apologies everybody, with everything going on tech-wise today, I'd forgotten the date, the time, and everything else. So it's not far away. On 2 p.m. on Thursday, the 28th of September, we are following up this webinar with a national virtual support group. Joanna will be joining that call, as will her colleague and Guy's colleague, Professor Joanna. So that's your opportunity really to have some more in-depth discussion, and it's more participative. And what we haven't been able to capture today on this webinar because of poor sound or issues, you can actually then take up with Joanna and expand on in that meeting. So please do either get in touch with us by phone. I'll put the phone number up at the end, or you can actually register for this through the website. But I think everybody who's on this call will also probably get a notification. Yeah. Do we have another slide? There we are. The buddy scheme. I mean, this is invaluable. If it's not something you've tried and you do really want to connect with somebody that understands, gets it, understands what you're going through, might be time served, and can help discuss general challenges with you from a patient perspective, or become a friend. Or if you want your time served yourself and you want to be able to pass your knowledge forward and help others, please get in touch, because we're always looking for people that could buddy others. That Leukemia Care will give you some background support and training to do that. And if you're somebody that would like to buddy with somebody else, please do get in touch with us. I'll leave the phone number up at the end just briefly for a little while. I talked about our advocacy caseworker. Again, please get in touch. Main source for many issues, invaluable as a patient. And again, if you're struggling if you're really struggling to pay your bills and and finance issues, please do get in touch with a welfare officer. She's there to help you. Next slide, please. An important one. We also have a counselling fund available to anybody who's diagnosed with a leukemia, MPN or an MDS. And that's friends, that's family, of those also diagnosed, as well as, patients. Get in touch with the charity. This is something that can be incredibly helpful. Sometimes it's very hard to try and work your way through things where, you're in a situation where you're isolated, you're dealing with some of the challenges yourself of living with the condition, navigating that, or family are also struggling. So that's there for you. Please do get in touch with the charity, or you can register through the website. Social media, we're always busy on social media. So Facebook, Instagram, and I think it's now called X. So we need to update that slide, but you can find out what's happening there, but that's somewhere that you can visit. And I think the last slide, well, CML, all cancer patients, all family, there are always ways where you can connect with others, and we just welcome any opportunities if people are interested in doing a little bit of fundraising as and when you may want to, or if that's the kind of thing you like to do. Have a look on the website. Plenty of opportunities there. Quite often really interesting group activities, with the end result being it helps others and raise funds so that we can help sustain the services that we're offering. I think there's just a last slide that'll be our numbers. From that point of view, I'll just leave this up. Here's the phone number. Write it down if you haven't got it. Use it. Don't be afraid to talk to people at the other end. And alternatively, just drop an email. If you email that address, that will go directly to our advocacy support worker, who will there be able to field that or signpost you to other information. So thank you, everybody. I've overrun slightly. We've overrun slightly. We've managed to navigate the challenges, and thank you, everybody that stayed on the call this long. I noticed that people did stay on virtually right to the very end before I shared their slides, because everybody's probably seen those before. So please have a lovely weekend, and hopefully my colleagues will be able to join you at the next meeting. And listen, I take my hat off to you, Joanna. I don't know if Guy's still with you. Just got to thank you for persevering. Really look forward to catching up with you in a few weeks. I think it's on the 28th, isn't it?
Thank you. So unfortunately, he's had to go, but it's been a real pleasure. Thank you very much. And I hope people have got something new or something to take away from the session. And I really look forward to the next session with Professor Dragoner as well.
Yeah.
Bye.
Bye-bye. Thank you for your help.
Bye.